Is that pantoprazole taking up a line? When should medications ever have priority over blood products? What are even the clinical benefits of medications we commonly give for esophageal bleeds? What's up, guys? Mark with PharmWise. I'm a board certified emergency medicine pharmacist that makes clinical pharmacotherapy content on the social medias. Thanks for joining me on the Code Blue Debrief, a clinical pharmacotherapy YouTube and podcast series. The focus of our discussion today is going to be on common medications given for acute variceal bleeds. Two high acuity patient populations that I had a lot of exposure to during my time as a COVID resident was obviously the COVIDs and also decompensated cirrhosis. Those who trained during this time in critical care and emergency medicine know what I'm talking about. When you work with severely sick patients, you tend to become a bit biased since you see the worst of the worst. Training during a time of severely sick COVID and liver bomb patients was an invaluable experience. It was a crash course on solid, consistent patient care workup in complex patients. Cirrhosis is one of my most favorite disease states to learn about. It amazes me how many complications are self-induced from a legal substance compared to other things that are considered illegal. Esophageal varices are one of those complications. Varices develop over time from increased systemic portal hypertension. They can eventually rupture from an overpressure, leading to hemorrhagic shock and a liver bomb with coagulopathy abnormalities. That's just one of many ongoing problems. There's only two outlets GI bleeds can go out of. Pharmacotherapies in the acute setting include acid suppression, vasoactive agents, and antibiotics. Let's review how systemic portal hypertension develops from a fatty liver. Decreased liver function from cirrhosis increases intrahepatic resistance and splanchnic vasodilation. Hepatic steatosis contributes to alterations in inflammatory mediators and increases portal hypertension. Varices develop from the pressure at the esophageal circulation point. These varices can eventually rupture from an overpressure. Sounds like you got an acute variceal bleed. Hemorrhagic shock would be our primary concern right now in severe cases. Hemorrhagic source control with prompt endoscopy is going to be our solution. Pharmacologic agents are crucial for pre- and post-endoscopy management, in addition to optimizing resuscitation. Interventions for hemorrhage control from endoscopy include bipolar, electrocoagulation, banding, and clipping. Most cases of portal hypertension in Western countries have underlying cirrhosis. Chronic alcoholism turns toxic to the liver, leading to structural abnormalities from fibrosis and inflammation. This process of scarring to the liver leads to increased portal hypertension, splanchnic vasodilation, and bacterial translocation. Pharmacologic agents to keep in mind for esophageal bleeds include pantoprazole, Acute, and ceftriaxone. Patients in hemorrhagic shock are going to need IV access for blood transfusions. Blood products are always going to take priority when it comes to access in these patients. Let's review the clinical benefits of these pharmacologic agents. It'll help you prioritize when time and access are limited. Proton pump inhibitors, or PPIs, suppress gastric acid secretion, increasing gastric pH. The initial load of pantoprazole in vivo increases gastric pH above 6. This environment promotes platelet adhesion and minimizes clot dissolution. Evidence supports use of PPIs post-endoscopy, with meta-analysis associating use with decreased rebleeding, blood transfusions, need for urgent interventions, and additional endoscopies. How about the acutely decompensating patient in the ED pre-endoscopy? What's the importance of acid suppression in this setting? There has been conflicting evidence on whether acid suppression for upper GI bleeds have clinical benefit pre-endoscopy. The 2021 American College of Gastroenterology Upper GI and Ulcer Bleeding Guidelines state we cannot reach a recommendation for or against pre-endoscopic PPI therapy for patients with upper GI bleeds. Literature is insufficient to support routine pre-endoscopic PPI, which is pretty consistent with other global organizations. But what does the clinical status of the patient in front of you say? As mentioned earlier, an IV bolus of pantoprazole 80 mg would raise the intragastric pH above 6. Pantoprazole IV is not compatible with many highly acute medications or blood products, making it not very ideal as a continuous infusion for the patient population. Studies comparing intermittent pantoprazole to the historically used continuous infusion associate the dosing strategies with similar safety and clinical outcomes. Sakar and colleagues completed a meta-analysis in 2014 comparing continuous infusion pantoprazole to the intermittent dosing strategy. Continuous infusion pantoprazole is dosed as 80 mg IV and then 8 mg per hour, while intermittent pantoprazole is dosed as 80 mg IV and then 40 mg every 12 hours. The primary outcome was rebleeding within 7 days, with additional outcomes including rebleeding within 3 and 30 days, need for urgent intervention, mortality, blood transfusions, and hospital length of stay. From their findings, intermittent pantoprazole was non-inferior to continuous infusion for their outcomes. The 2021 American College of Gastroenterology guidelines list continuous infusion or intermittent dosing pantoprazole post-endoscopy to be appropriate for upper GI and ulcer bleeding. Most times you never know when a patient can actually get arranged for a stat endoscopy while you're in the kitchen sink. I'm not delaying other therapies for pantoprazole, but if conditions permit, the IV bolus should be sufficient. Vasoactive agents are a mainstay of therapy for variceal bleeds. Octreotide, a somatostatin analog, is only available in the US. This medication reduces portal blood flow and pressures, inhibits glucagon, in addition to splanchnic vasoconstriction. Octreotide has been compared to several other agents and varying outcomes, including vasopressin, terlipressin, and sclerotherapy. These outcomes included mortality and rebleeding amongst others. The results of these trials show that octreotide was as effective and even more safe than certain treatment regimens previously used. The 2016 American Association for the Study of Liver Diseases Cirrhosis Management Guidelines reference a meta-analysis associating octreotide with a reduction in 7-day mortality and rebleeding. This led to the recommendation of octreotide being initiated as soon as possible in acute variceal bleeds. The dosing of octreotide is 50 to 100 micrograms as an IV bolus, followed by 50 micrograms per hour for 2 to 5 days. Octreotide 100 micrograms subcutaneously 3 times daily can also be utilized. Mechanistically, this medication targets the source of our problem and likely more reduces rebleeding than actual mortality. In the really sick, bleeding patient, I'm reaching for octreotide before pantoprazole, but second after prophylactic antibiotics. Patients with decompensated cirrhosis and variceal bleeding have shown the most benefit for prophylactic antibiotics, with several guidelines supporting this practice. Bacterial translocation increases the risk of infection, including for spontaneous bacterial peritonitis. Prophylactic antibiotics have been associated with a reduction in overall mortality, incidence of bacterial infections, rebleeding, and overall length of stay. Our agent of choice is going to be ceftriaxone. The prophylactic dose is 1 gram IV daily for 7 days, while the treatment dose is 2 grams IV daily for 5 to 7 days. Antimicrobials should always be tailored toward respective local antibiograms. with more evidence supporting downstream mortality benefit, prophylactic antibiotics in decompensated cirrhosis, and acute variceal bleeding is going to be my preferred pharmacologic agent of these three medications. Just keep to the basics and start, secure, and maintain your ABCs. It's easy to get excited about giving medications, but consider the importance of the pharmacologic agents in relation to the patient clinical status. Hemorrhagic shock needs to be resuscitated with blood with a target hemoglobin above 7. Stay on top of calcium salts during MTP and reverse anticoagulants when necessary. If conditions and access permits, I'd work my way through ceftriaxone, octreotide, and then pantoprazole as IV pushes. Let me know in the comments below, how do these pharmacologic agents fit in your practice for acute variceal bleeds? I appreciate you for staying to the end of this episode of the Code Blue Debrief. Make sure to hit the follow, subscribe, and notification bell. And lastly, there's been a lot of negative energy around the world lately. Just wanted to send some positive vibes your way, and I hope you learned something new.